This is Dr. Richard Nowak, Associate Professor of Neurology at the Yale School of Medicine. Today I'll be talking about FCRn antagonists, myasthenia gravis, and specifically focusing on treatment options. These are my relevant disclosures. So here we have the most recently FDA-approved treatments, and the way that I see these as falling into two main buckets. We have the neonatal Fc receptor antagonist, and then we have the complement inhibitors. So under the FCRn antagonist, we have efgartigimod, which is intravenous. We have efgartigimod, which is the hyaluronidase, which is the subcutaneous formulation. And then we have rosenelixizumab. These are all FDA-approved FCRn antagonists at this time. Then looking at the other bucket, the C5 complement inhibitors, we have eculizumab and revilizumab, which are both intravenous administered medications. And then we have zilucoplan, which is the most recently C5 complement inhibitor therapy that we have approved. I'll get into the details of each of these and some of the nuances in the upcoming slides. So looking at the treatments in late-stage development, we have a number of FCRn antagonists, nipocalimab and batoclimab specifically. These have recently completed phase 3 registrational clinical trials, so more information to come likely in the coming next several months with these. And then we have what we have labeled here under other, and these are the first one is a C5 complement inhibitor, but the others are targeting different aspects of the immune system. So what is myasthenia gravis? It's important to note that this is a T-cell dependent B-cell mediated via IgG autoimmune condition. So for instance, we have medications that target B cells. Inebilizumab, for instance, is an anti-CD19 B-cell depleting strategy. And that phase 3 clinical trial has recently been completed. And we have medications that target, for instance, interleukins, sartrilizumab specifically, and that phase 3 trial was recently reported. So again, the treatment landscape and late-stage development medications, it's important to follow the literature, but I think that as the years go on, we'll have most certainly additional targeted treatment strategies, so an ever-evolving therapeutic landscape for autoimmune myasthenia gravis, clearly. While our CME today is focused on FCRn, and the role of FCRn antagonists in myasthenia gravis, I wanted to at least highlight some of the key complement inhibitors that are available to us. First, we have eculizumab that was approved in 2017 by the FDA with a treatment indication being patients with acetylcholine receptor positive generalized myasthenia gravis. Again, this is a terminal complement inhibitor that specifically binds to the complement protein C5 with high affinity. It's a medication that, again, is administered intravenously, weekly for 4 weeks, and then maintenance doses given every 2 weeks thereafter. All patients need to be immunized against meningitis, and it does have a box warning against meningococcal infections. Revilizumab, again, was approved back in 2022 for the treatment of acetylcholine receptor autoantibody positive generalized myasthenia gravis, very similar to eculizumab in terms of its mechanism of action, but its administration maintenance is every 8 weeks. Again, meningococcal immunizations are required, and it has a box warning for meningococcal infections. Zilucoplan is a C5 complement inhibitor. It's a peptide as compared to the monoclonals that I presented in the prior 2 slides. It was approved in 2023, again, for patients with acetylcholine receptor positive generalized myasthenia gravis. It's administered daily subcutaneously by patients, so it's a self-administered. It doesn't currently have a box warning. However, as a C5 complement inhibitor, patients do need to be vaccinated against meningitis. So switching back to FCRn inhibitors / antagonists, efgartigimod was approved in 2021 for the treatment of patients with acetylcholine receptor positive generalized myasthenia gravis. And as noted earlier, this is an FCRn blocker or antagonist. it's given on a cycle basis. So what does that mean? Each cycle is given weekly times 4 weeks. And then the cycles then can be administered based on how the patient is doing clinically. So some patients have a 4 to 5 or 6 week break between cycles, and some patients can go for an extended period without requiring additional efgartigimod treatment. This medication does not require any vaccinations and does not have a boxed warning. So I wanted to touch on efgartigimod, ADAPT, and the ADAPT Plus study. So ADAPT was a placebo-controlled randomized phase 3 clinical trial that compared efgartigimod versus placebo. Again, these were weekly infusions, and then the separation from one cycle to the next cycle was 5 or more weeks, depending on how a patient did clinically. I'll point out that the eligibility for this clinical trial was those with generalized myasthenia gravis based on the MGFA class between 2 and 4, acetylcholine receptor autoantibody positive or seronegative patients, required an MG-ADL of 5 or higher, and needed to be on 1 or more stable generalized myasthenia gravis treatments, and had to have an IgG level of 6 or higher grams per liter. This study schematic also details, which I think is also important to understand, the open label extension, or ADAPT Plus, where we have patients on more long-term treatments for up to 3 years. And I'd like to share this data for you based on how patients did on long-term FCRn antagonists, specifically with efgartigimod. And again, this is looking at efficacy based on the MG-ADL score and the QMG score for patients with generalized myasthenia gravis. And again, demonstrating that those that received efgartigimod did better in terms of having a greater improvement in their MG-ADL score. So if you just simply compare, for instance, 2 or higher, over 80 or near 90% of patients achieve that bar, as compared to about 45% in the placebo arm. As you make the cut a little bit more strict, for instance, looking at a 3 or higher improvement in score, it's still 80, but then the placebo is closer to about 30%. Looking at the physician-reported clinical outcome measures, specifically the QMG, looking at a 3 or greater score improvement in total score, we have 64% as compared to about 27 or so percent in the placebo arm. Again, demonstrating efficacy in the ADAPT Plus, or in the open label extension study here. Then looking at safety in terms of treatment emergent adverse events, again, there was no specific safety signal identified that was of concern. I will point out that the most common treatment emergent AE was headache at 24%. There were patients that had COVID-19. Again, some of the study was done during that time at around 15%, and the nasopharyngitis was reported at about 13% or so. So again, no significant safety signals identified, but it's important to note as you use potentially efgartigimod in clinical practice that up to about 24% of individuals might report a headache with treatment, so not super uncommon from that perspective. So getting into some of the details with efgartigimod hyaluronidase, this was approved in 2023. Really, the only difference here is that this is subcutaneously administered, kind of as the main difference, but a clinical trial nonetheless was completed. Here, this slide is a schematic for the ADAPT SC study. So this is a study that compared efgartigimod sub-Q at a fixed dose to efgartigimod IV, which was a dose based on the patient's weight. The criteria for enrollment were essentially the same as for the original ADAPT: adults with generalized myasthenia gravis, MGFA class 2 to 4, ADL scores of 5 or higher, and on 1 or more stable GMG treatments. Here are the efficacy. So you can see the subcutaneous formulation of efgartigimod in green as compared to the intravenous formulation. Again, looking at the MG-ADL score change at the top left corner, the patients had drops in their MG-ADL scores. Looking at, for instance, the change from the study baseline of MG-ADL in those with acetylcholine receptor antibody positive patients, those actually had an improvement in those scores overall. And then the acetylcholine receptor positive population from ADAPT-SC+, which was the open label extension, we're looking at overall population, and they have improvement in their MG-ADL scores for the overall population as well as for the population of patients with autoantibody positive disease. Again, this is looking at the safety profile for ADAPT-SC as well as for the open label extension, which was ADAPT-SC+. No safety signals were identified here. We did note injection site reactions, headache, COVID-19 as being some of the more frequent AEs, and also some individuals with myasthenia gravis exacerbations. Again, no real difference between the groups identified here. Moving along to the next FCRn antagonist, which was rosuneloxizumab, approved in 2023. This was approved again for generalized myasthenia gravis patients who were either positive for acetylcholine receptor or MuSK autoantibodies. Again, this is a monoclonal antibody that targets FCRn. This is a medication that's given once a week for 6 weeks, and then subsequent treatment cycles are given based on how an individual patient is doing. So some patients do require additional treatment cycles thereafter. It's given as a subcutaneous infusion using an infusion pump. Again, no boxed warnings were identified or noted here. This is the MyCareNG study in terms of the study schema. This is to enroll a total of 200 patients into 3 arms. It was a 2-to-1 design where rosuneloxizumab versus placebo. And then the patients were re-randomized in terms of those who had completed or required rescue therapy into receiving different doses of rosuneloxizumab. So for rosuneloxizumab, we have the pivotal study, which was MyCareNG. This study enrolled a total of 200 individuals with myasthenia gravis. It's important to note that it also included patients with MuSK autoantibody positive generalized myasthenia gravis, a total of 21 individuals. This was a 2-to-1 design. So there were 67 individuals assigned to placebo, and then 66 and 67 assigned to the 2 different dosing arms of rosuneloxizumab. And looking then at the efficacy for MG-ADL score, we have the overall study population on the far right, looking at the change in MDL score, placebo versus the 7 mg per kilogram as compared to the 10 mg per kilogram, again, demonstrating clinical benefit in that overall population. But we also look at the AChR, which is the middle figure, demonstrating a significant change in that study population. Looking at our MuSK patients, again, the numbers here are a lot smaller in that there were a total of 21 individuals randomized in the MuSK cohort. And so some of the confidence intervals are a little bit wider, but we do see most certainly improvement in MG-ADL scores as compared to placebo in both of the dosing arms here. Again, overall demonstrating efficacy in either AChR and MuSK antibody positive generalized myasthenia gravis. This is looking at the not only the MG-ADL, but we also have the MG composite and the QMG scores. Important to note that we're seeing reductions in both of the additional outcome measures for each of these scores. Safety, comparing the safety signal, there were no safety issues identified with rosuneloxizumab in the overall population or in the MuSK versus AChR subpopulations here. Then this is our next FCRn antagonist that is currently with the FDA for review, pivotal trial was recently completed, but just to share with you that this is a monoclonal antibody that targets FCRn. It's administered intravenously, and more information to come depending on the decision that's made by the FDA. This is the phase 2 clinical trial that demonstrated safety and at least preliminary effectiveness that looked at nipocalimab at a total of 4 doses as compared to placebo. Here we have the efficacy as determined by change in MG-ADL score at the various different doses. So again, demonstrating that the ADL score does improve with the nipocalimab administration. Again, this was based on the published phase 2 clinical trial data, not the phase 3. Here's the relative safety. No safety signals were identified as compared to placebo. So our next FCRn antagonist, which is in late stage development, is batoclimab. This is a monoclonal that targets FCRn. This is given subcutaneously. The phase 2 clinical trial, which looked at both safety and preliminary efficacy, was a 1-to-1-to-1 design. And this study also included an open label extension period of batoclimab, and then a follow-up period that looked at safety and adverse events. So based on the efficacy information here, while this is a study that was underpowered, it demonstrated that patients did have an improvement in their overall MG-ADL score changes, but specifically, it was to understand whether or not there was a significant lowering in IgG and pathogenic autoantibodies. So based on preliminary efficacy assessed, the study was positive and moved forward to phase 3. But before we get there, I'd like to highlight some of the safety features of batoclimab in the phase 2. So again, looking at the different doses of batoclimab as compared to placebo, there was no specific safety signal identified or tolerability issues identified in phase 2. This led then specifically to the phase 3 batoclimab study, which is the FLEX study. And this is a study that included an induction regimen, as well as a maintenance regimen, as well as a long-term extension. So the study was designed to understand how much batoclimab or how much of an FCRn antagonist is really needed to achieve clinical benefit. So again, this is a study that was a 1-to-1-to-1 design, looking at batoclimab at 680 milligrams once weekly versus 340 milligrams once weekly versus placebo. And the primary endpoint was the change from baseline to week 12 in the MG-ADL in patients that had autoantibody positive myasthenia gravis. What's clever about this design and what this design might reveal is understanding thereafter as to how to administer batoclimab and how often to administer it and at what dose is necessary to administer it in the sort of maintenance of our patients with generalized myasthenia gravis. So more information to come as the phase 3 registrational trial is completed. And this next slide sort of summarizes the current FCRn antagonists available or currently in late-stage development. So we talked about today efgartigimod sub-Q, and rozanolixizumab. I will point out some distinguishing differences between those three just to highlight. So efgartigimod is a weekly intravenous administration times 4 weeks as a single cycle that can be repeat administered. Efgartigimod sub-Q is exactly that. It's a subcutaneously administered weekly treatment. And then the distinction between that and rozanolixizumab is that this is a medication approved for both AChR and MuSK autoantibody positive patients, again, subcutaneous weekly administration. Both nipocalimab and batoclimab are currently in late-stage development, and more information to come in the next several months. Our clinical pearls are as follows. Numerous therapies are approved and or in development that target FCRn and reduce IgG and pathologic autoantibodies for myasthenia gravis. There's currently 3 medications FDA approved that are FCRn antagonists, and there are 2 that are in late-stage development at this time. FCRn antagonists are blockers along with medications that interfere with the complement system or complement inhibitors, provide clinicians with more options to tailor treatments to care for patients and reduce burden of disease. Thank you again for your attention and participation in today's CME. Hopefully this is of value to your practice. Thank you again.